Our opening session brings together two senior leaders at the Centers for Medicare and Medicaid Services. Please join me in welcoming Chris Klomp and John Brooks. This conversation will be moderated by BMA's Mary Beth Donahue.
Thank you again, John. Thank you so much. Thank you, Chris. Thanks a lot. Well, welcome to Strengthening Medicare Advantage session. And again, just so grateful for John and Chris to be here representing CMS leadership and giving us their time. And I know many of you already engage a lot with them and with their colleagues and the administrator's office and the administration. This has been administration agency that has been very engaging and accessible to our ally partners. And having worked in HHS a very long time ago, I know what it means to be able to take the time away from your extended agenda and give any issue, in this case Medicare Advantage, your time. So thank you so much for being here. I just want to do a bit of an introduction of Chris and John. They have a very extended portfolio at the agency, and it's not enough that they already aren't playing roles within the agency itself, never mind the rest of the administration. Chris is director of the Center for Medicare, a deputy administrator, and recently took on the additional responsibilities of chief counselor to Secretary Kennedy and senior advisor at HHS. So running Medicare wasn't enough and has even more added, but we're very excited that his portfolio continued to stay within the center. John Brooks, Deputy Administrator and Chief Policy and Regulatory Officer at CMS, and as well recently appointed as Senior Counselor at HHS as well. So thank you both for what you do for the agency as well as the department. I want to get started into some specific issues in the broad MA portfolio, but first, Chris and John, if you could just speak to your expanded role at the department, your mandate as far as working within CMS and HHS as well.
Sure. So story's a little bit different for Chris, but for me, my portfolio in terms of working with HHS is really just supervising a lot of the work that's coming out of CMS and helping to coordinate across the department there, and then engaging with our partners at the White House, et cetera. So pretty similar role to me in terms of my expanded role in terms of my work as the Chief Policy and Regulatory Officer at CMS. Kind of spans that portfolio, and so it's kind of a natural fit.
Mary Beth, we're so grateful to be here. Thank you for having us. It's nice to see so many of you today. This is an important conversation. The expanded role is interesting. I'm very grateful to get to stay in the Center for Medicare. I have a lot of passion for the work that we do. I think we're the single largest budget in the federal government and arguably the most powerful regulatory component of it. And as you know, what we do in Medicare has trickle-down effects that affect all of the rest of U.S. healthcare. And so I think our passion sits in that space. My expanded responsibilities now as Chief Counselor for the department include running all day-to-day operations for the Department of Health and Human Services. So at least for the next foreseeable future, I'm spending a lot of time working well beyond Medicare and well beyond CMS across all of our operating divisions as we work to accelerate some of the president's priorities, further tighten our focus, and how we work together as a team.
Thank you. Well, again, as we all continue to engage with you, we'll continue to try to recognize your broad portfolio, and not everything is within Medicare. But again, appreciate your engagement across the board. And as we talk about Medicare Advantage, obviously that has its own broad portfolio, so we'll touch on a lot of different issues. But one area I just wanted to point to, because it was something you all had recently published, was in Health Affairs. And you both co-authored with a couple other colleagues, and it was about the coding differences between Medicare Advantage and fee-for-service. And the findings, differed significantly from what we had seen and heard from MedPAC on their estimates. And so if you can just share how you came to what you presented in that piece, and just what you think the implications are for policymakers as we think about what drives those differences.
Mm-hmm. Sure. So when we came to the agency, one of our top priorities around Medicare Advantage was just trying to figure out, okay, what is the current state of the program? obviously there's been a lot of literature about the program over the last several years, and it's been increasingly, I think it's fair to say, the tenor has been unfavorable. And so we really wanted to dive into the, kind of what's the truth here. And so we reached out to MedPAC. Chris, as soon as he came on board, was very passionate about this mission too, and helps facilitate a lot of the conversations with MedPAC initially. And our team basically worked with MedPAC to understand where their estimate was, which was at 10% in terms of the coding intensity difference between fee-for-service and Medicare Advantage, on top of the mandatory 6%. And our estimates, which were significantly lower as a team. And as we went through that process, and it's to MedPAC's credit that they were very transparent, they worked closely with our team. Basically, we identified kind of two different factors that were kind of leading to a lack of alignment between the numbers that we were seeing in terms of as we looked forward out into the future for the program, and MedPAC's analysis, which was of 2022. And basically, there were challenges in terms of the timing of the data and the purpose of the data, and then also fully incorporating the impact of V28. And basically what we found was if you looked at the static point in time, 2022, and looked at the data there, that was a point where Medicare Advantage was in a significant different place than it was in 2025 as we were moving forward and looking at our rate notice. And so a lot of the difference that we saw between the 10% that MedPAC had in our internal estimates was simply just a matter of timing. We were looking forward into the future. They were looking at a point in time in 2022. And so those are going to lead to different outcomes. The second major piece was V28 and fully understanding the impacts of V28. We saw that the V28 risk model adjustment basically significantly reduced a Medicare Advantage payment, as you would expect, and as the agency predicted when that was phased in over 3 years. And ultimately, what we found was that where MedPAC had 10% in 2022, when we were looking forward, we were seeing a difference of around 1.5% to 2%, and that was really helpful for us, and I think helpful for MedPAC. I know they've done some updates to their numbers since. And I think it, kind of highlights two things. One, it's really important for all of us to understand exactly what's going on in the program, recognizing the uncertainty there. Two, it's great when MedPAC and CMS can partner a little bit to share, compare notes, and understand the methodology. And three, and then I guess the third point is that it's really important that we share this information so that everybody who's, commenting on this program, which is so vitally important to so many of us and to our beneficiaries, have the best information available to move forward with policymaking. So that's a little bit of background there.
Thank you. As I mentioned, at the agency, MA has a broad portfolio and area of issues, and the administrator and both of you have been terrific leaders in innovation and modernization of the program, and again, in many areas where we're mutually aligned. One hot topic, obviously, right now is AI. And the RFI that many of us had responded to that CMS recently issued was seeking stakeholder input on improvements to MA. And what we want to sort of zero in on is specifically AI. And we're obviously all, regardless of what organization, company we're with, are seeing the rapid adoption of AI across healthcare. And whether or not it's in care coordination, utilization management, or clinical decision support. And so if you can just share how CMS is thinking about AI's role in Medicare Advantage going forward, and what you may foresee appropriate oversight to be, and just what you think we should be looking ahead and trying to be partners with you as you're looking at that.
Yeah, so we just finished, Dr. Oz runs the Center for Medicare by a system called Objective Key Results. Some of you are familiar with this. John Doerr wrote the book on it from Kleiner Perkins. The objective is, where is it that we're trying to get? It's not a KPI, key performance indicator, the soulless sea of numbers. This is a big step change forward if we want to move not from how the world is today, but how we wish it to be tomorrow. What do we need to do? So the objective is, where are we going? The key result is, how will we recognize when we get there? And conspicuously, we stop short of saying how. We leave that to the teams. And if the teams understand where we're going, then they will recognize the best solutions, because the best answers to problems usually don't come from the top. Most leaders understand that really well. He certainly does. And so we finished a 2-week intensive session as a team, a weekend intensive session as a team, refining our OKRs for the year 2 weekends ago. And embedded in nearly every major component is AI. And for good reason, not just because we believe there's opportunity for us to streamline and improve what we're doing at CMS and across the department broadly, but more importantly because I think we're talking about AI as an industry as though it's a foregone conclusion that it will be the solve for all of our problems. It's going to make all provider burnout go away. It will solve all administrative problems. It will eliminate all challenges to rev cycle. It will be perfection when it comes to clinical diagnostics and treatment plan design. It will solve care navigation problems, and patients will never have to worry about that again. It will be the answer to everything they want, the best medical mind in their pocket. And certainly that's the utopic vision, and it is within reach. It is possible. I'm convinced this will be the single most transformative technology in well over a century, certainly more than the internet. But we should not take for granted that it is a foregone conclusion that it is going to fix all of these problems. And we've talked about this before, I'll say it again. Healthcare has a stunningly impressive ability to take a phenomenally powerful disruptive technology and pile drive it in the ground and get exactly zero value from it. And you know this is true, you laugh because it's a sad truth. The internet came along, and yet it's 2026, and when I moved my kids' medical records from Utah to DC, it still involved CD-ROMs and fax machines, right? My wife just got a referral to a specialist. They said, please fax over all the records, like hundreds of pages of records. Like, what? Really? Like, so internet, like that didn't work. You know, then we rolled out EMRs with tens of billions of dollars of meaningful use and thought, well, gosh, that's going to be amazing. We're going to pool all this data together. How great. We're going to have longitudinal records, and that's going to surface all these magical insights. And in some respects it did, but largely then that just created a problem of interoperability. And now we're sitting, we have fragmentation, and now we have networks upon networks upon networks. We didn't really solve that. You know, the list goes on. We give you a lot of them. AI has the risk of falling into that category. And so it's embedded in all of our priorities. And fundamentally, I distill three core truths that must be so in order for us to actually unlock the power of it. Number one, we must have interoperable data. It's 2026. We can no longer be held hostage by assuming that data is going where it needs to be. It must be wherever the patient needs and wants their data to be, full stop, while they have control and privacy. That's it. We can't be held hostage any longer by gatekeepers. Number two, there's a regulatory framework that did not contemplate artificial intelligence. Everything assumes human in the loop, and in many respects, that continues to be appropriate. But there are deregulatory actions that we can take and must take in order for AI not to become an and, but an or, to unlock deflationary forces, to actually extend access as a physician extender, not to replace clinicians, to be clear, to extend them, because we have access issues in this country. I'm reminded every time I go to the dermatologist, it's 9 months. Heaven forbid I have to reschedule because I have to travel unforeseen. It's 9 months. And yet we have people dying of skin cancer. Why? Because they don't get early detection. It's one of the most preventable forms of cancer ever. So that's a good use case for AI and computer vision. Let's do that. Let's extend the capacity of our physicians. And number three, we need a deflationary payment mechanism. Right now, most of healthcare is still indexed off of, frankly, original Medicare fee schedules and benchmarks. These are time-based constructs. So we use relative value units. We multiply them by a conversion factor. That's what we pay. I had an entrepreneur come up to me at a conference last year. They built this really interesting AI technology in radiology and said, hey, we think we're going to bill through this CPT code. And I just wanted you to weigh in. It's billed in 15-minute increments. Do you think we could bill 2 units of time? To which I responded, like, I will go out of my way to destroy that code if that's what you decide to do. Because that's the exact opposite of what we want. AI thinks in cycles. It uses tokens. We don't think about it in time. So that's what, you know, our colleagues at the Center for Medicare Medicaid Innovation are tackling. Abe Sutton, Jacob Schiff, brilliant individuals with the access model. We pay for outcomes. We do that based on a rate that's implicitly deflationary. It's disruptive. It requires and empowers insurgents to do something differently. And so AI is amazing. It has all sorts of possibilities. We're embedding it in everything that we do. The question then is, where do we go? Right now, no question, we've seen mass uptake in rev cycle. Candidly, that's a little worrisome to us, right? We see a lot of armament on the provider side, not just in optimizing coding, but actually increasing the intensity of services rendered per visit, but we don't necessarily see corresponding improvements in outcomes relative to that intensification per visit. That's a little worrisome. On the flip side, we see payers that are trying to swat this down, and so they're arming. There's Lord of War sitting right in the middle. We needed the time. We need those beautiful minds that are focusing on those areas to focus in other areas. Let's focus on the providers who are spending, we were at AMA last week, 2 hours of administrative overhead in their practices per 1 hour of clinical care. Let's change that. Let's fix that burden. Let's alleviate their burden. Maybe they can get home and see their families at night, be healthier and render better care. Happy physicians, that's better. That's happy patients. That's a good outcome. So huge opportunity on administrative burden reduction. And then, of course, the Holy Grail is, in fact, for every patient on the planet to have access to the best medical minds. And that's the promise of AI. Like, that's the ability, but we have to do it safely. And so our colleagues at the FDA, along with many of our other sister agencies across the department, are spending real time thinking through what are principles-based frameworks that ensure that where necessary, there's human in the loop, but we're not being rigid. We're not preventing AI from continuing to evolve. We're not certifying a single model. How are we balancing challenges of transparency with intellectual property rights so that we incentivize capital to flow in and create these new technologies? But at the same time, we have controls and safeguards. We're aware of what they're doing. They're not introducing bias or discrimination or other adverse events into the clinical workflow. And so these are complicated topics that we'll continue to wrestle with because it's new for everyone. This is completely a de novo playbook, but it's exciting, it's extraordinary, and I think it can actually be massively deflationary and could solve this existential question that we should all be wrestling with, that we're wrestling with now. You mentioned the advance notice that we're wrestling with, which is categorically what we're doing right now isn't working. We're spending $15,500 per capita on healthcare per year in this country. The industry is growing twice the rate of GDP. It's 18+% of GDP, and it's a net negative productivity industry. And we are sicker than we have ever been as a country. Higher chronic disease rates, soup to nuts, going the wrong direction. So let's just start there as a source of truth and build from there. And then understand what is the role of MA, what is the role of AI, what is the role of so many of the things that we need to wrestle with so that we actually leave the country in a better place for our children than we found it. Because at the moment, I'm not sure that's true. That's a problem. Anything you'd add on the AI front?
Nothing to add to that.
Get off that. Everybody's like, get off that soapbox.
Well, no, but I mean, we have providers, we have physicians here, and so for you to be able to speak to how you're taking on this complicated issue, and impressive you start with just the OKR effort led by the administrator, so important, but just the optimism you have and realizing that there are opportunities here. And so however we can be a part of that effort and just appreciate as we looked at that RFI to zero in on that area of AI.
I will say you use the word optimism. I am optimistic. Like, these are real challenges. One of the things I love about our country, and I genuinely believe it's the greatest country in the history of the planet, is that when you back America into a corner, we innovate our way out. We do it every single time. We are so darn good at that. Mm-hmm. And this is that. We're reaching that peak point, inflection point, but I bet on us. I bet on American exceptionalism. Like, I am an entrepreneur by background,
yes.
So the word no literally doesn't compute in my mind. There's a really personal reason, which John understands, of why that is, but it's true. And so these are nothing that we're talking about today. Mm-hmm. None of this is intractable. There's reason for great optimism and hope. But we have to be willing to wrestle with the hard questions. Mm-hmm. And that means that there are going to be winners and losers in these questions. We always talk about more, right? We take hundreds of meetings a month. Like our Dr. Oz talks about, we are open for business. Mm-hmm. I think most of you in this room know that because we've met with most of you, and usually yes. more than once. We go out of our way to be on the ground, listening, meeting, grabbing ideas. Mm-hmm. And it is rare that we decline something. And in that process, I think there's just an opportunity to wrestle with not just like, I'll often hear folks come in and say, we want to be part of change. We want to do this thing, but not my profit pool. Just leave that one alone. But all the rest, let's go for it. We got to be honest with, gosh, maybe the way that we're making money right now or where the source of margin is at the moment might not be where the source of margin ought to be tomorrow. And yet if we start with what the right answer is first, it's a $5 trillion economy, people. Like, there's plenty to go around. But let's start with doing the right thing first, and then let's back into how we make that sustainable for each stakeholder who participates and adds value.
Well, thank you. And again, this is a stakeholder audience, so they hear you loud and clear.
I believe it.
So, Chris, you did mention the advance notice, and I do want to recognize, as we bring up this topic, obviously we're in the middle of the regulatory process right now, and so it's gracious for John and Chris to be here for us to even bring up the topic, so CMS can't speak to any specifics about the advance notice. Looking forward as far as understanding an independent analysis that we're going to have presented today from the Berkeley Research Group that shows that in the risk model changes that were proposed, that there could be a negative impact on seniors. At least that's what the analysis is showing. And in the rate notice, it would show that total payments to MA plans would be reduced and possibly cost $27 PM, and seniors would look at that as over $300 per beneficiary annually. That would hurt them, and that's not including the growth rate assumptions. We recognize that the agency and the administration are committed to stability and predictability, and that is a thread that you've spoken to, and it's shown through in a lot of your different policy efforts. But recognizing that when we see results like that in an analysis, if you could just share how, when we see that raising concerns, how that, how does CMS look at that kind of data coming in? If you could just speak to it, and how do you see that showing how CMS balances payment accuracy with the program stability?
Yeah,
And that commitment to stability and predictability.
Yeah, I mean, I've talked a little bit just a few minutes ago about some of our efforts to guarantee long-term program stability, which is first, we need to have a good grounding in the data. We need to understand how the program's operating. And so, our argument is always that the road to stability goes through greater payment accuracy. We need accuracy, and we need to restore public trust, which I think was faltering a bit in Medicare Advantage among a lot of stakeholders 12 months ago, 24 months ago. And so I think that we're working on rebuilding that trust. And as we do that, we need to work through the process of guaranteeing payment accuracy. And so one of the things that we've done, and Chris has spearheaded a lot of this work, is invite a lot of stakeholders in to comment on the advance notice. We've taken a lot of meetings, said, share with us your assumptions, bring your assumptions to us. We've read, the analysis that from Berkeley Research Group that you're going to be talking about later today. We want to understand the truth about this program. It's very easy to take a piece of this program, run away with the characterization, and then write a headline and summarize a story. But it's harder to take a comprehensive look to understand exactly where the flow of funds are, where are plans coming in against a benchmark, how much in rebate dollars are actually available, how is this actually comparing to fee-for-service and the fee-for-service benchmarks, which Congress has asked us to look at as we set Medicare Advantage rates. So we're going through all of that process. We appreciate all the input. I mean, obviously, there's been a little bit more input this year than we typically get. I think our team shared with us that this is a record. I don't know, Chris. If you could speculate later, that'd be great. Our team shared with us just this morning that they had a record number of comments this year. That could be another innovation related to AI. Who can tell? But in any case, we do want to get to the right answers. We're working towards stability, and that remains the kind of hallmark that we're working towards as we seek to create a sustainable program for beneficiaries.
I'd love to just build on this for a moment in terms of our broader feelings for the record about Medicare Advantage, in case there's a question mark, because some of those headlines that we've seen are, well, this must be a turn. It turns out the industry doesn't like Medicare Advantage, or this is a way of somehow, casting a viewpoint on MA. That would be inaccurate. So let me be clear. Dr. Oz likes to talk about how poor quality care is the most expensive care. When I look at all of the quality metrics that we track, and by the way, remember, we have really three forms of Medicare. We often talk about it like it's two. It's not. It's three. We have original Medicare, fee-for-service, right? You might tack a Medigap plan on top of that. We have accountable care. It sits under MSSP generally, Medicare Shared Savings Program, or it could be under a derivative or a successor CMMI model, REACH, LEAD, et cetera. And then we have Medicare Advantage. So we have three forms. And it is not incumbent upon us, nor is it our statutory directive from Congress, to tell a beneficiary where they should be. Our job is to manage all three forms of that program. It is to pay accurately. It is to ensure that we are able to extract the maximum value for the stakeholders that we are charged to serve by Congress. And we only have two stakeholders that we serve, beneficiaries and taxpayers who help fund the program. That's it. Now, obviously, there are many other stakeholders in the equation, and if we aren't satisfying and meeting their needs, then they are unable to serve our beneficiaries. So there's the provider community, there's the payer community, there are other service providers, operations, et cetera. Why do we care so much about this? Why are we here with you today? It isn't to give an accounting of the advance notice, right? We can't do anyway because we're in the comment period, or we'll close the comment period moving toward the final notice. It is for you to understand, why do we care so much about this program? Because when I look at every single quality metric, when a beneficiary is in an accountable relationship, a serial relationship with a provider who has an aligned set of financial incentives relative to that individual's well-being, they understand their personal goals. They understand what it is that is success to them, which may not be success to the other patient, what their goals are. It's a grandmother who wants to hold her grandchildren longer. It's a grandfather who wants to be able to climb a hill a little bit longer. When they understand that, they outperform on quality. Sometimes it's tens of basis points of difference in a given metric. Sometimes it's more. But when you multiply that across a population, you compound that over a decade or 2 decades, we'll have a Medicare beneficiary about 17.8 years on average. We see massive improvements in population health. These are individuals who lead healthier lives. When they lead healthier lives, and we've said it before, they meet their full potential, and we are better positioned as a country to meet ours. And we are in the business of helping people live healthy lives. Our mission is helping Americans live to their full potential. That is CMS's mission, stated by Dr. Oz as the administrator. That might seem like a rather lofty mission, but it's not. You can't reach your full potential when you're sick. You don't feel well. You don't want to get out of bed. And so we care about Medicare Advantage, and we care about accountable relationships, accountable care organization relationships, because they lead to healthier individuals, healthier Americans. So we care about this program. We have to think about it on the quarter and the year. It needs to be sustainable. There needs to be stability and predictability. We understand that. That's important to us. We don't take that lightly. Those aren't just words. This actually keeps me up at night. It also has to be sustainable over the long term. John mentioned trust. There has to be trust by beneficiaries. There has to be trust by our legislators on the Hill. They have to believe that we are being wise stewards of the taxpayer dollars to which we've been entrusted to us. We have to give an accounting to them of this. We do this every year. And so we're balancing this equation. We're thinking about all of these different variables, and this multi-stakeholder group plays an essential role in that. And so Medicare Advantage, for example, cannot simply be a margin tack on to an underlying original Medicare benchmark. Some would accuse it of having been that. If so, that's not constructive. We need you to wrestle with cost. We need to make sure that you're deploying services to their highest and best use for the good of the beneficiary. Not all benefits are created equal. Some are very squarely aligned toward improving population health. Others, like when I see a Chili's gift card, you got to squeeze a little, or squint a little bit, and wonder if, I don't know, the salsa is a tomato, and I guess that's a healthy thing, but maybe that's not the best thing on a prepaid card for the beneficiary. Are we deploying to the highest and best use? Are we being wise stewards, not just of our resources, but as providers and stakeholders in the community? Are we being wise stewards of the beneficiaries who've spent their whole careers paying into this program? And they're counting on it when they turn 65. They're counting on us. They're counting on us to be there, to be predictable, to be stable, to meet their needs, to help them live their healthiest lives. And they've contributed to our country. The least that we can do is be there for them and do everything we can to help them meet their goals and objectives. So if there's any question, I hope this puts it to bed. We care deeply about this program. We care deeply about Medicare Advantage. It is an essential component of the future of Medicare. Choice and competition is something you referenced earlier. Why does that matter? Because the beneficiary is much better suited to choosing what form of Medicare they want than we are. We should not tell them that. But we should help them figure out what that is. My dad's been on Medicare Advantage now for many years. By the way, he switched to his third plan in 3 years because plans have been cycling in and out of the marketplace. That keeps us up at night. We care about that. That lack of stability is not a good thing. He goes to his broker and sits down each year and has that person go direct them. He also has, by the way, a great ACO in his backyard. I'm not sure he understands why that ACO might be a better choice for him or a lesser choice for him. That's incumbent on us, on all of us, to help him make that better decision. so that he can do the things that he needs to do to meet his full potential. So we care about stability. The advance notice matters. That predictability matters. But we, again, need to wrestle with the hard questions. How are we managing underlying medical cost? Are we deploying our resources against their highest and best use? How do we drive predictability and stability, both near-term, married with long-term program integrity and stability as well? And integrity is a component that we should talk about as well. It's obviously on our mind.
Well, and Chris, it's definitely been clear, the agencies and your all personal commitment to predictability and stability. And you mentioned in all of this, there's a lot to balance. Recently, Allies sent a letter to Administrator Oz about their some of their concerns with the advance notice, at the same time expressing why, whether or not they were speaking for beneficiaries, and why beneficiaries are choosing the program for affordability, for access to benefits, or those organizations who serve those seniors who are seeing how it's helping them deliver good health outcomes for seniors. But as you have this stakeholder audience here, when they're trying to understand the affordability piece and you already mentioned it, the rising costs and aging population medical trends, how do they understand, and again, this goes over years that precede you all, of where there were payment changes that had a negative impact. But how do you speak to stakeholders' views where they don't see payment policies or recommendations that are keeping up with the aging population and medical trends?
You want to start?
Look, I would say broadly, this is why we're taking so many meetings. This is why we're actually reading the comments. I did wonder, by the way, this is my first stint in government. I wondered if CMS actually reads the comments. Like inside baseball there, we actually read the comments. Like comment period.
All 40,000.
Like comment period closes and like that weekend is comment weekend, and it's comment palooza. Like,
and
people,
we should all keep that in mind as we're continuing to reach out to CMS to realize the time that your team needs to spend looking at those comments. And thank you so much for giving us the opportunity
but
to
we
comment, because we
actually
don't take that for granted. And when we hear from you and your colleagues, bring us the data, bring us the data to support what we're saying. That's on all of us to follow your lead. And if we don't do that, then we're not taking advantage of the process.
I can assure you, you're doing that this period, and we're taking it seriously. And so, as John mentioned, we've taken many meetings during the comment period where we have asked folks to come with data to come help us understand, what are you seeing in the market? What are you seeing in underlying medical cost trend? How do you think about the implication of a particular policy decision for your place in the market? You might be a small regional plan. You might be attached with sub and global cap provider groups. You may not be. You might be part of a national plan. It's going to have disproportionate impact depending on your vantage point. We want to understand that. We want to have a thriving competitive marketplace. That means we need multiple distinct stakeholders in Medicare Advantage to be able to participate. You could be small, you can be large. We want a level playing field. It's hard to achieve a level playing field, but we're charged with doing that. Why do we want that? Because it gives more choice and competition. That's a good thing for consumers. Competition tends to raise the consumer experience. That's what we want. It's more adaptive. It pays attention to the needs in a more responsive way. So the comments are real. The meetings are real. We're grateful for it. You educate us. You help us see things, right? We don't want to be in an ivory tower. We're not, it turns out. You know that. We're in the market a lot, talking to all of you. So I would just encourage you to keep it coming. Nothing.
Yeah. No, I mean, I think that's exactly right. Like we take the meetings, we read the comments, and again, we're committed to creating a stable program because we think this is an incredibly valuable and meaningful option for beneficiaries. The value that MA generates over time is almost hard to calculate. If you think about just the bids every year, well, for most years, we've seen that MA can provide a tremendous amount of value. It can provide the same benefits as fee-for-service at a much lower cost, and then share value back to the patient. The patients then, with the supplemental benefits, get access to benefits they otherwise wouldn't have. And that's extraordinarily valuable when you're thinking about dental care, when you're thinking about vision care, when you're thinking about different things that seniors working on a stretch budget find an invaluable part of their daily financial planning and their health. And so, we care tremendously about this program. We appreciate the input, and that's why we're here today. And that's, as Chris said, please keep the comments coming.
You know, as you think about the advance notice, you all know this, there are effectively three key components, right? You've got the effective growth rate, the EGR at the top line. That's largely a function of an actuarial calculation. Obviously, there are assumptions that go into that. We have a phenomenal team of actuaries who've been doing this for a long time, who think very deeply. They also continue to listen and learn and incorporate new data and new assumptions. And they've continued to pay attention and read the comments and take meetings and learn and listen in this process as well. With a great degree of humility, and I'm grateful for our colleagues there. Then we have our technical changes, right? This time in the advance notice, that was roughly 3%. That's the model updates. That's the basis of the model. Right? How do we think about the periods? This year we proposed moving from 2017 and 18 diagnosis and expenditure information respectively to 23 and 24. Then there's an implicit set of normalization adjustments that run concurrent with that, with puts and takes. So there's that second component. Again, they're technical adjustments, it's math. But there's still assumptions that go into that. And then the third component is policy assumptions, right? Policy objectives. You saw us propose a policy objective in this instance related to unlinked chart reviews. The value behind that principle is something that we don't get a lot of disagreement on and haven't heard a lot of consternation about. If I find something in a patient's health risk assessment and that increases their coding intensity, then Medicare is going to pay a little bit more for their premium. Why do we do that? So there's not adverse selection, so that somebody's not discriminated against if they want to be able to choose a plan. We're going to pay a little bit more because presumably they're going to need a few more services. So we'd like to make sure that that patient's providers are engaged and they're helping them be healthier based on their condition. Now, how we accomplish that is an open question, but we've been very clear about what the policy objectives are, and we're eager to get feedback on the best way to effectuate those policy objectives. But what is the policy objective in case there's any ambiguity? We do not want plans competing on the basis of risk adjustment. That should not be a source of margin. It should not be a source of competitive advantage. We want plans competing on the basis of helping beneficiaries live better, healthier lives on a cost-adjusted basis for the resources that we have at our disposal. So we don't want people playing games on the risk adjustment side. Now, how you play that game of whack-a-mole and how you eliminate those inefficiencies, that's the question, and that's where we're looking for feedback from all of you. And by the way, just stepping back for a second, not as a regulator, but as a citizen, I'm so grateful for the system that we have. I'm so grateful for a democracy where people, our regulators, sit and they do their very best work. We have an extraordinary career team that think deeply about this program. They love their country. They love this program. They work so hard. We could be in a shutdown or otherwise. They're cranking. They're doing their thing. Right? But then, and they put their best work out to the whole world, which sometimes loves it and sometimes torpedoes it. But we have this open comment period where every citizen is free to share their best thinking and advice, and then have regulators take that back and consider it carefully and then modify their decisions as appropriate using their best judgment. And then we finalize and we roll out, and then we listen, we learn, and we watch. That's democracy. That's a beautiful principle. What a privilege it is for us to get to sit and participate in that program on this side of the house. But you all get to participate as well, and you're doing it. In that process, you exercise your civic responsibility and your privilege. And we're grateful. I don't take that for granted. That's an incredible opportunity.
It is, and we do not take for granted the opportunity to comment. And thank you just for putting it in perspective of how you receive those comments and just see the value of that process.
Happy to.
So we have a little bit of time left, and I just want to switch gears because I know just recently in talking about the advance notice, it's about the broader MA it's a MA program, it's about protecting it, but also the need that we need to do to also strengthen the program. And when Administrator Oz was so grateful and spoke to us spoke to this group, us collectively last fall, it was about the areas of reform for the program and where we could improve the program for the beneficiaries. And whether or not it was administrative burden, care coordination, more transparency. And if you both could just speak to where do you see the areas where the stakeholder group could collaborate more, and where could we be more effective partners? And we know there's already some areas that were aligned, prior authorization and some of the marketing changes, but if you could just speak to where we could be collaborative partners.
Yeah, I think prior authorization is obviously a place where we've had a collaboration, but I think there's more that we need to do because, it's just such a point of friction for beneficiaries and for patients. And we all know cases, and we've all experienced cases in our personal lives where, relatives or ourselves have been stuck waiting for a prior authorization to come through. And, these are extremely vulnerable, life-changing moments for patients. And so we need to work on that, and we need to continue to improve that process. Chris led a convening process that resulted in a lot of great commitments in the middle of last year. And we're looking forward to seeing those pledges all executed on, as well as additional improvements. And I think AI is obviously another place where we could have opportunity here to streamline a lot of things. So I think that that's one area. I think risk adjustment as a whole, as Chris said, one of the things we're trying to do is remove that or mitigate the role of that as a source of competitive advantage. And again, there are technical levers that we have there, but there's also kind of, Medicare Advantage at a broad level is a collaboration. It's collaboration with beneficiaries. It's collaboration with plans that are trying to provide these benefits and manage care networks, and it's a very complex process. And then it's a collaboration with us and other regulators and legislators. And I think all of us need to step back and recognize that, the things that might lead to a particular margin growth over a quarter, if they're overall leading to a deterioration of everybody's view of the program, then that is not ultimately in the interest of beneficiaries. It's not in the interest of the Medicare Advantage program. And so I think that there's opportunities to work there. Both, we need your ideas because obviously the seat of all wisdom is absolutely not the Humphrey Building. It doesn't look like it, and it isn't. So we need your ideas there, and in terms of how we can lever, and we also need to look for other opportunities to collaborate. I don't know, Chris, what you'd add?
I mean, that's excellent. I agree with all of that wholeheartedly. I'd also say one of the beautiful things about Medicare Advantage plans in particular is that you're very close in the market. You're closer in the market than we are in original Medicare, right? You're seeing, you're responding, you're accountable to beneficiaries, you're working closely with providers. If you don't do a good job, you don't treat them well, that isn't a fair relationship, then you lose. You lose beneficiaries, you lose providers, you don't have network adequacy, you have all these different challenges. I think that we, CMS, can do a better job partnering with you to do your job, which is to appropriately manage cost and benefits relative to the objective health outcomes that an individual beneficiary seeks. What do I mean by that? So, for example, a plan last year announced what was ultimately a very controversial proposed policy related to remote patient monitoring. A lot of pushback, right? Both from that industry, from providers, others. When I look at the data in that space, there are some incredibly invaluable tools, and there's no question that the ability to drive RPM into the home, to drive earlier detection around prevention, proactive engagement for the patient are marvelous. There are also possibly some stakeholders in that space that aren't adding as much value as the cost that they're imposing to the system on behalf of the patient. And the MA plan correctly is sitting and saying, we're looking at our data and we want to make sure that if we're going to pay for this, it's going to add value to our patients, our beneficiaries. We, CMS, need to show up and give you air cover to do that job. Because if we don't manage cost, if you aren't spending every dollar on its highest and best use to the need or benefit of the beneficiary, then that's a dollar that's not going where it needs to be. It's a dollar that's causing the program to grow unsustainably, and then we have to have difficult conversations. Those are less constructive. And so there's opportunity for you to take all the things that you're seeing in the marketplace and bring them to us. Bring us your roadmaps and sit and say, we think we need to be investing more here. We think we need to be investing less here. And read us in early, and let us help you figure out how to accomplish those for the good of our beneficiary, for the good of the providers who care for those beneficiaries. That needs to be a collaborative relationship, right? We need to be partners,
Right. And
not
it's
just
also really
regulators.
helpful for us in the fee-for-service space. So if there are great techniques and there are great options there, we have CMMI and we have the ability to build out models in the fee-for-service space so that if we have an innovation that MA plans have recognized that's really contributing meaningfully to patient care, the ability to deploy that across fee-for-service could realign the entire care model across the system. And so those ideas are really welcome too, especially as we enter the next 3 to 5 years and watch the kind of transformation that we could see from AI.
Thank you. I'm going to leave it there because I love how Chris and John have just put forward, I would say, a directive to us all here to bring those ideas. And as we're sitting here saying that we're committed to strengthening the program, it's on us to be bringing those ideas and where needed that information forward. So I'm going to leave it at that. And just Chris and John, thank you so, so much for your time today. And I apologize, we weren't able to be structured in a way to take questions, and that wasn't on the officials from CMS, that was in our programming. And again, as you know, they've been quite accessible and ever since you've been in the agency. So thank you so much.
Thanks for having us. We appreciate it. Thank you.